terms of disparities, one of the things that I think we need to pay more attention with now that we've made so much progress in CML is the fact that that progress has not reached everybody the same way. The unfortunate nature of advancing patient care, that getting better treatments, is that sometimes those better treatments increase the disparities, the healthcare disparities, because those who have access to the good treatment, to the good monitoring, to the good care, do very well, but those who don't then stay behind, and that difference amplifies. And we unfortunately have evidence that that happens not only in the US. We've done an analysis, for example, in Georgia, and depending on what county you live in, your outcomes could be completely different. But all over the world, there's countries where there's been very little research, there's very few drugs available, there's very little opportunity to monitor those patients, and the impact in the what we call the disability adjusted life years is still huge, and we really haven't made any progress. So I think it is something that we need to start paying more attention, that we need to work on ways to address those disparities and the impact that it has in every disease, but certainly in diseases like CML, where we have so good treatment and made so much progress. And the other element that I touched upon was the issue of this monitoring and how we've addressed these. I think we've learned a lot about how to monitor. We've made a lot of progress in standardizing the monitoring. We've developed good guidelines as to what are the optimal goals at given time points, which are good as guidelines. I think the problem that I see we're facing is that we become too obsessed about the PCR value for a patient, and we seem to just only focus on the PCR, and sometimes we try to get every patient to become completely undetectable and the deepest molecular response. We change constantly drugs when a patient could do well without reaching those deep responses. And the problem is that when you constantly change, you create more risks for other toxicities, you create anxiety for the patient, you may increase the cost of care. So it is good to aim for a deep response. Obviously, as a goal, that is good. We all want that for our patients, and hopefully every patient would be eligible for treatment-free remission. But the fact is that not everybody is going to get there. We know that at best 50%. But the patients who don't get there, if you manage them well, they're going to have a normal life expectancy. They can have a very good quality of life. You can adjust their doses so that they have minimal toxicity. So the way I see this is that, to me, these deep molecular responses, aiming for those responses, is what I call that. This is a measure of success, not a measure of failure. Meaning, yes, I want my patients to get to that point, and I aim for that, and I put them in the best position I can to aim for that. But if they don't get there, but they're doing well overall, I don't need to be changing the drugs and exposing them to other toxicities and other things just to do that. It's not a failure to have some detectable disease if the patient is doing well and having a good quality of life. So I think we need to understand that these are guidelines, that the PCR is only one of the elements of the holistic management of a patient.